Hi friends, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh. I am also the medical author of the book Focused Neurology. Today we are going to talk about a fascinating topic, nystagmus. But my approach will be how to diagnose a person suffering from nystagmus, whether peripheral or central. So it will be a simplified, clinical oriented approach. So what is nystagmus? Nystagmus is an involuntary rhythmic movement of the eyes. Nystagmus is an involuntary rhythmic movement of the eyes. It has got a slow phase and then a fast phase. But nystagmus is mainly named after the fast phase, after the fast component. It's very interesting to know how this nystagmus was compared initially to a sleeping person and then when he wakes up from the sleep. As I said, nystagmus is a slow phase followed by a quick corrective fast phase. So it was compared to a sleeping person. So how does a person sleep when sitting? He just falls like this and immediately wakes up like this. He falls like the slow phase and then he immediately wakes up like this, a fast phase. So this is how this nystagmus was compared and derived from a person who sleeps. That was for history's sake and for generating interest. Alright. Now, as I said, nystagmus, the basic approach, the clinical approach, very useful for a clinician is to find out whether it's a peripheral cause of nystagmus or a central cause of nystagmus. Peripheral cause of nystagmus, what we mean is the semicircular canals, the inner ear and the vestibular apparatus. Central cause of nystagmus, what we mean is the brainstem and cerebellum. So if a person gets nystagmus because of the inner ear, labyrinthine apparatus, vestibular apparatus, you call that as peripheral nystagmus. We not really worry about it because most of them are benign. But if it comes because of the cerebellum or brainstem, it is a central cause of nystagmus. We need to be worried about it. It's a matter of concern because it's going to be dangerous. And therefore our first primary approach as a clinician is to find out whether it's a peripheral cause so that it is benign and we need not worry about it. Whereas if it's a central cause where we need to really worried about it and take immediate measures. So now let's see how we go methodically in finding out whether it's a peripheral cause of nystagmus or a central cause of nystagmus. In between, whenever there are some essential points, I'll talk about it. So the first thing is to look at the direction of the nystagmus. In peripheral nystagmus, it is unidirectional with a fast phase by beating away from the lesion. Peripheral nystagmus is unidirectional. What does this mean? When I look to the right, if the nystagmus, the fast phase is beating to the right side. When I look to the center, it is still beating onto the right side. When I look to the left, it is still beating onto the right side. So the direction of the nystagmus remains the same irrespective of my change in the head. This is known as unidirectional headache. Of course, what I said could be divided into 3 grades. So when I look to the right, if I have the fast phase to the right, you call that as grade 1 nystagmus. If I look to the central primary gaze and then still I have a fast gaze of the nystagmus to the right side, it is a second grade. When I look to the left, still I have a nystagmus to the right side, you call it as a third grade nystagmus. So first grade, second grade and third grade nystagmus. So peripheral nystagmus is unidirectional. That means when I turn my head to the right side also, the eye beats only to the right side. When I turn my eyes to the left side also, the eyes beat only to the right side. It is this unidirectional. So this is of some relief for us. Unidirectional nystagmus, we need not worry. It is a peripheral cause of nystagmus. But how does a vestibular apparatus or inner ear produce nystagmus? The vestibular apparatus, imagine I'm taking the example of my left side. When my left vestibular apparatus is stimulated because of VOR, vestibulo-ocular reflex, it connects with the 6th nerve on the opposite side and the 3rd nerve on the same side. So medial rectus on the same side and lateral rectus on the opposite side. So when my left vestibular apparatus is stimulated, my eyes will go to the right side. So when my left vestibular apparatus is affected, my eyes can't go to the right side. My eyes will deviate to the left side, and as a compensatory, the frontal lobe, frontal eye fields number 8 will try to push the nystagmus, the fast phase, to the opposite side. So in a vestibular nystagmus, since this cannot move the eyes to the right side, the opposite right vestibular apparatus will overact and will push the eyes to the left side, and therefore as a compensation, nystagmus, I'll have it to the right side because of my left frontal lobe. So in a left vestibular lesion, eyes will be looking towards, the slow phase will move towards the side of lesion, and fast phase will move away from the side of the lesion. So if the slow phase is intact, it indicates that the brainstem pathways are intact. And the fast phase, as I said, is because of the frontal eye fields area number 8. So if a frontal lobe is intact, frontal eye fields area number 8 is intact, you get the corrective nystagmus. So just by looking at the nystagmus, we can find out whether the brainstem is intact and the frontal lobe is also intact or not. So left side vestibular lesion, if it is there, eyes cannot move to the opposite side, eyes will move to the same side, and the nystagmus will be to the opposite side. Why should the vestibular apparatus try to push the eyes to the opposite side? It is because to maintain vision, to maintain an image correctly on the fovea, which you call it as vestibulo-ocular reflex. But for this vestibular-ocular reflex, when we turn the heads to either side, right side or left side, we'll get blurring of the image. Imagine I am looking at the camera. My eyes, my head and eyes straight. Suppose I look to the left and my eyes also move to the left, I cannot really focus on the camera and the image appears blurred. But if I turn my head to the left side and my left vestibular apparatus gets stimulated and my eyes still keep going to the right side, I still keep focusing on the camera and the image appears sharp. And therefore, the vestibular ocular reflex helps us to maintain the image correctly on the fovea so as to make it appear sharp. Otherwise, it gets blurred. This is a basic pathophysiology of vestibular ocular reflex. So when the vestibular ocular reflex gets affected, when the vestibular apparatus gets affected, eyes will move to the same side and the nystagmus will be to the opposite side. So this is a unidirectional nystagmus. So this is a unidirectional nystagmus with fast phase beating away from the lesion. Again, we have an very interesting acronym, COWS, cold, opposite, warm, same. If you put warm water, you are stimulating the vestibular apparatus. But if you put the cold water, you are making the vestibular apparatus inhibited. You are inhibiting the vestibular stimulation, and therefore eyes cannot go to the opposite side. Eyes will move to the same side and nystagmus will be towards the opposite side. So cold water, opposite side nystagmus, warm water, same side nystagmus. Right. When we look at the central lesions, the nystagmus may be bidirectional. What does the bidirectional nystagmus mean? For example, if I look to the right side, the fast phase of the nystagmus will be to the right side. But then when I look to the left side, it changes the direction and starts beating now onto the left side. So this direction changing nystagmus is known as bidirectional nystagmus. It is going to be dangerous because it generally indicates central pathology, either the cerebellum or brainstem, usually the cerebellar lesions. So if you have a bidirectional nystagmus, it is a central cause of nystagmus, either cerebellum or brainstem, usually cerebellum. So what is bidirectional nystagmus? When I look to the right, the fast phase beats to the right, but when I look to the left, it changes the direction and starts beating to the left side. So this is known as bidirectional nystagmus. So when you look at the bidirectional nystagmus, there are three important subcategories of this bidirectional nystagmus which indicate that it is a cerebellar pathology. One is rebound nystagmus, second is PAN, periodic alternating nystagmus, third is Brun'S Nystagmus. Rebound nystagmus is that the nystagmus, the fast phase beats to one side, Then when it comes to the primary gaze, it changes the direction and starts beating to the other side. So this is known as rebound nystagmus, a bidirectional nystagmus. So rebound nystagmus, the nystagmus beats to one side when I look to the right side. Then as it comes to the primary position, it then starts beating to the other side. This is known as the rebound nystagmus. Second, we have periodic alternating nystagmus. What does the periodic alternating nystagmus suggest? Here the nystagmus, again when I look to the right, it keeps beating to the right side and then it pauses for some time, for 1 or 2 seconds, and then starts beating to the left side. So this is also bidirectional nystagmus, wherein the fast phase beats to one side, passes for some time and then starts beating onto the other side. So bidirectional nystagmus, direction changing nystagmus after a pause, you call that as periodic alternating nystagmus. It is very much suggestive of cerebellar pathology, usually the pontocerebellar lesions, acoustic neuroma. Then we have the Brun'S Nystagmus. Again, it is a bidirectional nystagmus, a direction changing nystagmus. It is large and coarse on one side and then becomes fine on the opposite side. So we have three types of bidirectional nystagmus: rebound nystagmus, periodic alternating nystagmus, and then Brun'S Nystagmus. These usually indicate that the lesion is in the cerebellum. Right. Then when you keenly observe the nystagmus, the peripheral nystagmus usually is a transient mixed torsional component, especially in benign positional paroxysmal vertigo. It is a transient phase, that means it subsides after some time. It is a mixed, that means it could be horizontal torsional or vertical torsional. So it's a mixed type of nystagmus. Why you don't have a purely horizontal or purely vertical, why you get a mix of all the components in the peripheral nystagmus? The mix of the directions occur because there are three semicircular canals in the inner ear, each semicircular canal giving rise to a particular direction and vector, and therefore when the inner ear gets stimulated, when there is a inner ear disease, labyrinthine disease, the labyrinthine nystagmus is a summation of all these three directions, and therefore there is generally a rotational component. So when you don't see a pure horizontal or a pure vertical, but it is a mix of all the three directions component and it is a rotatory or torsional, it is more likely to be a peripheral cause of nystagmus. So the three semicircular canals beats in more than one direction, the summation of which creates a rotatory component. So you have the torsional nystagmus. Whereas in central cause, it is mostly pure nystagmus, purely vertical nystagmus. So when you have a purely vertical nystagmus, it is more in favor of a central cause. When you have a torsional nystagmus, it is more in favor of a peripheral cause of nystagmus. Here, I need to talk a very interesting and important concept, HINTS, H-I-N-T-S. What does this mean? H-I means for head impulse test, N for nystagmus, and T is for test for skew. So what is head impulse? As I said, if the vestibulo-ocular reflex is intact, when I turn my head to the left side, eyes will go to the right side. So eyes will slowly, smoothly go to the right side, and you can observe that. But imagine my left vestibulo-ocular reflex is impaired. My vestibular apparatus is affected. So when I tilt my head to the left side, it is not able to stimulate the eyes to move to the right side. So eyes also turn along with the head. Then there's a catch-up nystagmus to take up the fixation. So when you see the catch-up nystagmus, so head and eyes move together, then it suddenly tries to go to the right side to catch up. So if you see this catch-up saccade, that head impulse test is positive, then it indicates it's a peripheral cause of nystagmus. And then you have to look at the direction of the nystagmus. As I said, if the nystagmus is horizontal, you need not really worry about it because it is mostly peripheral cause. Whereas if the nystagmus is torsional, if the nystagmus is purely vertical or bidirectional, you need to worry because it's a central cause of nystagmus. So if the nystagmus is purely horizontal, it is most probably a peripheral cause of nystagmus. But if the nystagmus is vertical or bidirectional, it is most probably a central cause of nystagmus. So HI is for head impulse, N for nystagmus, and T is for test for skew. Especially, as I said, if there is a vertical nystagmus, you need to be worried because it is most probably either a brainstem or cerebellar pathology indicating a skew. What is skew? A vertical misalignment of the direction of the eyeballs, that is skew deviation. So now you are testing for skew. So if there is a vertical misalignment, it usually indicates a central cause of nystagmus. As I said, vertical phase of nystagmus is usually due to a central cause. So how do you test for skew? I told in the other class when I was talking about these reflexes, we need to know one important law which is known as Sherington's law of reciprocal innervation to understand testing for skew. What is Sherington's law of reciprocal innervation? According to the law, when impulses, excitatory impulses are sent to agonist, inhibitory impulses are sent to antagonist. So when the excitatory impulses are sent to agonist, inhibitory impulses are sent to antagonist. For example, if I want to lift dumbbells, my flexors, that is my biceps, will contract because excitatory impulses are going to the biceps, but then my triceps have to get inhibited, have to relax. Otherwise, I can't lift dumbbells if both are contracting together. So if agonists are contracting, antagonists have to relax. If agonists are relaxed, antagonists will contract. So this is the basic pathophysiology of testing for skew. So in skew, imagine my left eye is affected. So what happens? Imagine my superior rectus is affected, and therefore when I try to look at the object, for example this camera, and tries to fix up, both eyes are used for fixation, but my left superior rectus is affected, and therefore when I close my left superior rectus, left eye, this eye takes up the fixation, and therefore since there is superior rectus weakness, I will go downwards according to Sherington's law of reciprocal innervation. Excitatory impulses to agonist and inhibitory impulses to antagonist. So when the agonists are inhibited, antagonist will overact, and therefore when my superior rectus is weak, the eye will move downwards. So the moment I uncover the eye, what happens? I can see the movement of the eye which was inferior now suddenly trying to compensate and go up. So when you see this movement going up or down, the vertical misalignment after you uncover the eye, it indicates that there's a pathology in this vertical movement, and therefore again more in favor of a central cause of nystagmus. So Hinds is a wonderful test by which we can make out whether it's a peripheral or a central cause of nystagmus. So you do first HINTS. HI is for head impulse, N for nystagmus, and TS is for test for skew. Head impulse, you do it to find out whether there is a peripheral cause of nystagmus because of the catch-up second. Then you look at the direction of the nystagmus. If it is purely horizontal, it is peripheral. If it is vertical or bidirectional, it is central. If when you test for skew, when you cover the eye, if there is a superior rectus weakness, under the cover the eyes will go inferiorly, and then when you uncover the eye, again it goes back to its normal position. You can see this vertical movement. If that is present, it is again more in favor of central cause of nystagmus. Fine? Right. Now another important point is that the peripheral cause of nystagmus can be inhibited by visual fixation. So they are suppressed by visual fixation. So when you put Fresnel glasses, it suppresses the fixation, and therefore you can see the nystagmus in a magnified manner. So the peripheral nystagmus is suppressed by or inhibited by visual fixation. If you put Fresnel glasses, it inhibits visual fixation, and therefore the nystagmus is well seen, magnified when we use Fresnel glasses for a peripheral cause of nystagmus. Whereas if it is a central cause of nystagmus, they are not inhibited by visual fixation. Central cause of nystagmus is not inhibited by visual fixation. And then we take a peripheral cause of nystagmus. Usually, since it's a peripheral cause, usually there will be associated findings like hearing loss. If you take a central cause of nystagmus, again there will be associated findings of brainstem involvement, namely dysarthria or diplopia, or if cerebellum is involved, ataxia. So if the associated findings of hearing loss is there, it is more in favor of peripheral cause of nystagmus. If associated findings of dysarthria, diplopia and ataxia are there, it is more in favor of central cause of nystagmus. And then, especially for peripheral cause of nystagmus, we have a very interesting law which is known as Alexander's law. So what happens in peripheral cause, when my left vestibule is stimulated, my eyes will go to the right. If it is inhibited, it will move to the same side and the nystagmus will be towards the opposite side, towards the right side. So according to the law, if the fast phase of the nystagmus is towards the right side and I also start looking to the right side, the nystagmus, the velocity of the nystagmus, the intensity of the nystagmus increases. This is Alexander's law. So according to the Alexander's law, labyrinthine lesion beats away from the lesion and it increases in the direction of the eyes, which are turned in the direction of the quick phase. So it starts increasing in the direction of the quick phase. This is Alexander's law. So when there is a fast beating nystagmus away from the lesion and I also start looking in the direction of the quick phase, the nystagmus starts increasing. This is a peripheral cause, Alexander's law. And then we have a very interesting nystagmus in the central cause of nystagmus, which is known as Convergence retraction nystagmus. You find that in the midbrain lesion, dorsal midbrain lesion known as Perinaut syndrome. In Perinaut syndrome, where the top of the midbrain gets affected, you have a very interesting phenomenon, convergence and retraction nystagmus. Convergence and retraction nystagmus. The top of the midbrain is the center for all the vertical eye movements, supranuclear eye movements. So the midbrain is involved and the supranuclear eye movements coming to the third nerve nucleus is involved. The pons is intact, so sixth nerve is intact. So in a dorsal midbrain lesion, in the Perinaut lesion, Perinaut syndrome, what happens is that since the pons is intact, sixth nerve is intact, but the midbrain, there will be stimulatory disinhibitory impulses coming from the cortex, and therefore the third nerve, especially the medial rectus, starts firing now. So when the medial rectus starts firing, which are not balanced by the sixth nerve because pons is intact, so there will be convergence. So the third nerve medial rectus fires, there is convergence. Third nerve medial rectus fires, there is convergence. It is not balanced by the sixth nerve, so it will not go laterally, it will go only medially. So this is convergence part. Why do we get retraction? As I said, this third nerve supplies all the cranial nerves except lateral rectus and superior oblique. So the superior rectus and inferior rectus is also supplied by the third nerve. So when you get a disinhibitory impulses, the superior rectus and inferior rectus supplied by the third nerve also will overact, and therefore sixth nerve and third nerve will overact. The third nerve, the superior rectus and inferior rectus will overact, and then it starts retracting the eye. So superior rectus, inferior rectus, superior rectus, inferior rectus. So it starts retracting the eye. So very interesting phenomenon. You find retraction, the convergence retraction nystagmus, it indicates a dorsal midbrain lesion, a Perinaut syndrome. So this is all about nystagmus. As I said, where the most important approach of nystagmus is to find out whether it's a peripheral cause of nystagmus or central cause of nystagmus. You have many number of ways of finding out whether it's a peripheral cause or a central cause. Peripheral cause of nystagmus, you need not worry, they're all benign. But central cause of nystagmus, you have to be really worried. You have to take immediate measures because they are dangerous. I've enjoyed giving the lecture on nystagmus. I hope you have also enjoyed listening to my lecture on nystagmus. If you have any suggestions, comments, kindly post on my YouTube channel, Dr.Sreenivas Medical Concepts. And if you like my lecture, please like and subscribe to my YouTube channel, Dr.Sreenivas Medical Concepts, and my FB page, Dr.Sreenivas Concepts. Thank you. Bye.